with a historical topic like this, it's interesting to look at the history of GIST. And I think certainly the drug therapy of GIST rather mirrors my own journey as a consultant. I became a consultant in 2001, and the biggest oncology meeting in the world, ASCO, had GIST and imatinib at its plenary session. So GIST was top billing with imatinib at the biggest cancer meeting in the world in 2001. When I got to Leeds, where I now work, in 2005, and then started in sarcoma in 2006, things had moved on hugely. Imatinib was now a completely accepted drug, and many patients who'd been in the trials in the 90s were still in clinic and doing very well. It's possible some of you are some of those patients. At the time, we were taking part in trials of sunitinib, and sunitinib went through trials, expanded access program, and is now NICE approved, as you know. We now have a third drug license through the Cancer Drugs Fund. And just in a fairly short career, I think I've seen how GIST has, the treatment and management of GIST has moved on hugely, and we hope the same will happen over the next few years. There's some new people here, and this is just something of the basics, but I'm going to run through it very quickly because, as I said earlier, many of you know this. It's rare in that it's only 1% of all gastrointestinal tumours, and about 10 to 20 per million per year get it. There is regional and national variation. Median age of diagnosis is in the very productive years of 50 to 60. But of course the pause GIST, and I know that you've got to talk about this later on today, so I won't labour that, is well known and affects much younger people. GIST generally develop in the wall of the gastrointestinal tract, although EGIST, extragastrointestinal GIST, is described intra-abdominal development of these tumours. People wonder whether they might be metastases from unknown primaries, but they may well develop in those areas. And they express KIT, or stem cell factor receptor, so these are KIT is a transmembrane receptor, tyrosine kinase. So it does things inside the cell. If you signal to it with a receptor, with a factor like stem cell factor, then KIT starts various processes which do things in the cell. In GIST, KIT is mutated in most cases, doesn't need a growth factor, it just kicks off on its own all the time and does things in the cell, including not very useful things like growing and spreading and surviving when you'd rather it didn't. So how GISTs present, this may be familiar to you as well. People may present with anemia, or bleeding, either chronic anemia, starting to feel tired, short of breath, chest pain if they have a tendency to angina, or with a more acute bleed. Sometimes people get pain, sometimes the tummy gets bigger because there are tumours in the tummy. The liver may become enlarged, but quite a number of GISTs are diagnosed incidentally. Someone has a scan, someone has an operation, and that's just found when no one was expecting it. And the primaries, about 2/3 start in the stomach, a quarter in the small intestine, the majority of the rest in the large bowel, and a small proportion in the esophagus, in the gullet. And the picture there, which the people at the back probably can't see, I'm sorry about that, just emphasizes the fact that these are tumours that start in the wall of the bowel but tend to grow outwards. They're in the supportive tissues. And so some of you may have had experience that people suspected something was wrong, had an endoscopy, an examination of the inside of the stomach or something, and the lining of the stomach was normal or the lining of the bowel was normal. And that's because the tumour sits under the bowel and is often growing outwards. The other issue with that is that these tumours can grow quite large before anyone knows anything's wrong. Tumours that grow into the bowel will tend to block it or bleed. Tumours that grow out, everything else just accommodates itself around it, and you may not know anything's wrong for a long time. And that can be why people can be found to have quite large tumours. So in the past, and this is up until about the 1980s, so well within living memory for most of us here. GISTs were just thought to be a very difficult to treat soft tissue sarcoma. So we all knew about smooth muscle tumours, leiomyosarcomas, or the ones that looked rather more bland and boring were just thought to be leiomyomas. Sometimes people thought there were other things. If there was a bit of nerve tumour in there, something that looked like nerve, you'd call it a nerve sheath tumour and so on. But the thing that was difficult with GIST, these sarcomas that happened in the gut, was that if you gave people chemotherapy, the tumours didn't shrink. If you gave people radiotherapy, the tumours didn't shrink. And so the surgery was a mainstay of treatment, and people would often have many, many operations, and because there was nothing else you could do for them. The entity of GIST, or gastrointestinal stromal tumour, was first described as a group of tumours that were different from the standard smooth muscle tumours in the 1980s. At around the same time, in 1987, c-KIT was described as a variant in mammals of a viral oncogene. So oncogenes are genes that, when they mutate, cause cancer, and these were being described in viruses, often causing cancers in animals. And then people started looking, as they could start looking at DNA for the first time, found that mammals had a variant of this as well. It was found to be a receptor, something that goes through the membrane, and then the factor that binds to it, stem cell factor, or steal factor as it was sometimes called in different laboratories, called it different things as they discovered them. People started looking at what the signaling pathways were inside the cell, and then in 1998 it was found that most GISTs had a mutation in KIT. So things were moving quite quickly, but different people were concentrating on different things. Some people were working on the pathology of a particular sort of cancer. Other people were working on receptors. PDGFR, or platelet-derived growth factor receptor, is a close relative of KIT, and a minority of GISTs have got a mutation in PDGFR as well, or instead of in KIT. So we knew more about the biology of this, but there was a parallel story going on, and that was rational drugs design. As people could understand more about the structure of proteins and the structure of drugs and the very advanced chemistry that was going on, people were looking at the oncogene BCR-ABL, which is active in chronic myeloid leukemia, and developing a drug to block the activity of this molecule. And a lot of drugs were screened, and imatinib was found to block this. And incidentally also, because a panel of different tyrosine kinases was looked at, was found to block KIT and PDGFR alpha as well. And so you had a drug with a target, and you had a disease which had a target. And these stories were brought together by some people who said, well, how about trying imatinib in GIST as well in CML, where it was beginning to look quite promising. They did some preclinical work, took some GIST cells, found that imatinib blocked the signals, and so the phase 1 studies began. And the first phase 1 study was presented in, I haven't got the original one, it was published in The Lancet in 2001, and those were the data that I heard when I went to that big meeting at ASCO. But because publication, as you probably know, takes a while, people already building on the results of the phase 1 study, and the phase 2 and 3 studies were continuing, and the license was granted in 2002. So that's the past. I'm sorry if you can't see this graph, and this is a graph from an ASCO presentation, and also published in The Lancet. And the EORTC, the European Organization for Research and Treatment of Cancer, did a study comparing imatinib at 400 milligrams a day and 800 milligrams a day, and found that in unselected patients, this is well before mutation analysis was routine, there was really very little difference in the response, or rather the overall survival. There's a bit of difference in response in people with exon 9 mutations. But just for comparison, they put on the historical control of patients treated with standard soft tissue sarcoma chemotherapy, the drug called doxorubicin. And you can see the survival there is clearly worse. Now, we always worry about historical controls, but with graphs that are as separate as that, I think you can accept that imatinib is making a big difference. So the present management of GIST, many of you will know this and many of you will be living it. The standard treatment is imatinib 400 milligrams a day. At the moment, we're not using 800 milligrams a day. That's something that's occasionally discussed, and we could talk about later if you want. According to NICE, we should be evaluating response every 12 weeks. What we found is that some of our patients are ending up with scans in well into double figures, and after patients had about 20 scans, you wonder what you're doing. And so we tend, with patients, particularly with a favourable mutation who've been stable for over about a year, we tend to do 6 monthly scans, although we're still seeing them every 3 months. If you have a patient with a suspected GIST where there isn't biopsy confirmation and people have tried very hard, still don't have confirmation, serial PET scans can be useful. So you do a PET scan, check that the tumour lights up, which you'd expect for a GIST, start imatinib, repeat the PET scan 2 weeks later. If the activity has gone down significantly, you've got your diagnosis. If it hasn't, then you've also got, you've excluded a sensitive GIST and you can stop imatinib. Mutation analysis is now routine for patients with advanced disease, I think fairly generally now. And there are groups of patients in whom you have to be particularly careful. So some of our patients present with very advanced disease, may have metastases, large primary tumours, which are not surgically removable, and you may start imatinib straight away. In those patients, there has to be a concern that the tumour may bleed. And so with those patients, our practice in Leeds used to be that we'd start them on a small dose and work them up, but actually I'm not sure that there's any evidence that that helps, and all that does is extends the time when you're most at risk. So now we just start with standard dose if patients are well enough, but see them once a week just to check they're okay. And that's less about us being very clever in clinic and picking up the bleed that happens as they walk into the hospital, and much more about people getting used to us and us picking up the side effects of imatinib. And people with other health problems, people with heart failure, for example, who couldn't tolerate the fluid retention that can happen with imatinib, we might be a bit more careful about and maybe start at a lower dose. So I mentioned mutation typing or mutation analysis. So that's just a cartoon of KIT at the top, but it could just as well be, PDGFR alpha is a similar sort of structure, although the exons are a bit different. Can I get the mouse to work? So exon 11 is just on the inside of the cell, here close to the cell membrane, and exon 9 codes for a bit of protein just outside the cell, but also close to the cell membrane. And this is where the majority of mutations, are, and this is where you get the sensitivity to imatinib. If you have mutations further down inside the cell, then these tumours are resistant to imatinib, and these are the areas where GIST can acquire mutations later on after a while of treatment. The other thing to note is that although patients with a mutation in exon 9 are less likely to have a long response to imatinib, they're more likely than other patients to respond to sunitinib. So it's useful to know. And there's just a graph there of how long patients are controlled depending on their mutation status with imatinib. So exon 11 patients are usually controlled for longer, but then are less likely to respond to sunitinib. This is from George Dimitri's paper published in 2002, just showing how quickly you can get a response on a PET CT scan. So on the left, this is a patient with a large tumour in the abdomen and pelvis, and black shows that it is using up a lot of sugar. So this is a tumour that's active and growing. After a month of imatinib, that's switched off, and after 16 months, it's still controlled. The other bits, those are the kidneys, that's the bladder, that's the heart. They're all allowed to light up, and those don't present tumours. How do you assess response? I've mentioned CT scans. Traditionally in oncology or cancer medicine, we've given chemotherapy, and if something's got smaller, we've been happy, and if something's grown, we've been unhappy, and if something stayed the same, we've been a bit disappointed. So something like this, we'd be very happy. This is, if this patient were in a trial, these are slides from Dr. Belusu in Cambridge. If this big tumour gets much smaller, we're very happy, and we say that's a response. However, in this patient, they have a big tumour, they've had some chemotherapy or some imatinib, and the tumour's the same size, and you might be a bit disappointed in that. But actually, you shouldn't be, because the tumour's got darker, that's less dense, it's gone mushy in the middle, it's gone cystic, and this is much less active. And the statistics on the outcomes of patients in trials show that if you have stable disease but a reduction in density of the tumours, actually people stay controlled for as long and live as long as people who get shrinkage. They may still have problems because the tumours are bulky, but from the point of view of survival and being well and not needing to adjust treatment, they're doing all right. And that's an important piece of information. It means that if you see this, you shouldn't be thinking about changing treatment. Sometimes when you start your treatment, you find surprises. And again, in oncology, we're simple-minded. If you get new tumours, you worry. But what you can see when you start imatinib is that new things appear that look less dense. So this is someone with a scan through the top of the liver. It looks fine at the beginning. And then here you see something new appearing. You think, oh my goodness, it's all gone horribly wrong. But it hasn't, because there was just a little tumour there that you couldn't see on the scan, and the imatinib's killed the middle, and you can see it now. That's all right, that's a response, and you carry on treatment, and that's actually encouraging. I mentioned people who can't have their primary tumour removed. Sometimes it's just too big, it's sitting near to important structures. Removing it at the beginning might cause problems. So people with a gist of the rectum, for example, the tail end of the bowel, if you remove it straight away, sometimes with a bulky tumour, patients might need to have a stoma. And sometimes that's unavoidable, but sometimes if you shrink the tumour down, you might be able to avoid that. So, and occasionally there may be other things. So if a patient can't have a general anaesthetic because they've maybe had a heart attack recently, you might give them imatinib while their heart recovers and control their tumour, and then they have their surgery a bit later. So in those circumstances, we might give imatinib before surgery, and that's for about 9 to 12 months, and then there's a decision about whether to give adjuvant imatinib. Professor Wall will talk about adjuvant and the various settings and the considerations there. I think if you know that you had a bulky tumour to start with, you might well be thinking about adjuvant. In a tumour where it looked more favourable to start with on your scans, you might not need to give it. But what it looks like under the microscope, counting mitoses after 12 months of imatinib, may not be very informative. So you can't use the usual risk classification that we normally do at diagnosis after immediate surgery. Unfortunately, imatinib doesn't cure gist that's already spread. And the experience is that even if you've treated people for 10 years and everything looks all right and you stop the imatinib, eventually the tumours will start to grow again. And so we usually don't do that. We know that it's usually safe if people need to stop imatinib for a while, that you can do that because in most cases if you restart it, the tumours will come under control. There was a French study that showed that 85% of people who stop imatinib when they're controlled and the tumours grow again, that 85% will regain control of their disease. But in most cases, if we see gist growing, it's in people who are still on imatinib. So this is an example, again, from Dr. Belusu. This patient, this is his liver, or her liver, I don't know. There's the less dense lesion, but there's a little nodule in it. and that's a site of progressive disease. Now, what do you do about that? Well, if it's a single site, if this were a patient with several sites of disease and just that one, you might do a local procedure. We're not in the market now of doing lots and lots of liver removals of bits of liver, but you can remove a bit, or you can do radiofrequency ablation or cryotherapy or various other things that the liver surgeons and the interventional radiologists do. But in general, if the GIST is escaping control, you're looking at second-line treatment, and I've already mentioned sunitinib. And sunitinib inhibits KIT. It actually inhibits KIT better than imatinib because it's a smaller molecule, so it can get into the molecule more, into the receptor better. It also does other stuff. So it's inhibiting new blood vessel formation, and it also inhibits other oncogenes. Now that's useful because it'll bypass various resistance mechanisms. However, if you're interfering with blood vessels, you are setting yourself up for problems, and those are particularly high blood pressure, protein in the urine, and sunitinib does other stuff. It can cause rashes, which can be problematic and interfere with thyroid function. And so it's not always very straightforward. Also gives you stripy hair. So mutation status, sometimes you might look at someone and say, well, exon 11 mutation, otherwise not very fit. Sunitinib may not be the best plan because it may not work very well, might be too toxic. In other settings, you might look at it. So this is just showing the time of disease control. Patients with wild type or exon 9 GIST are controlled for a lot longer than people with exon 11 GIST. Now this is an old presentation now, and the numbers were very small, but I think we're still concerned about people with exon 11 mutations. And this is just a graph that you may have seen before. This is sunitinib versus placebo in the original registration sunitinib study. There was concern that maybe it should have been compared to carrying on with imatinib, but that's a study as it was performed. So now sunitinib can work. Tends to work if it's going to work for 6 months to a year, and after that you're looking at third-line treatment. We now have regorafenib, which is available in England through the Cancer Drugs Fund. Just like sunitinib, it inhibits KIT, a range of vascular endothelial growth factor receptors, so it's going to interfere with blood vessel formation, and other oncogenes as well, including oncogenes from the RAF family. So some GIST harbor mutations in BRAF, and so that may potentially be useful. And the GRID trial published last year, which showed that progression-free survival on regorafenib was significantly longer than on placebo. Again, the concerns with placebo. Hard to interpret overall survival because the vast majority of people who progressed on placebo then went on to regorafenib, so there wasn't a big difference in survival. Regorafenib has side effects, fairly similar, I think, to sunitinib, what you'd expect, the diarrhea, high blood pressure, and also hand-foot syndrome, which you also get with sunitinib, so redness and cracking and pain of the hands and feet, and that can be troublesome, but usually fairly manageable. Nearly finished now, just look, so I think that's the state of play at the moment. What about the future? Well, we haven't finished with the drugs. Nilotinib was, I think, quite interesting a few years ago. I think it's now no longer being developed unless anyone tells me different, because I think that the trial suggested there was too much cardiac toxicity. People were having too many episodes with heart attacks and things. So it's no longer being developed for GIST, although it's being developed in other contexts, and it's being used in CML. Masitinib is being looked at in both the first and second line settings. I think the interesting thing with masitinib is that it does not inhibit VEGF receptors. Now that means that you're not going to interfere with new blood vessel formation, which is sometimes important in cancers, but on the other hand, you don't get the high blood pressure and the heart damage that you can get with sunitinib and regorafenib. And those trials are recruiting at the moment. Sorafenib is out there. That's a drug that mostly inhibits RAF, but also inhibits KIT and is active at exon 14. And then in the patients who don't have a mutation in KIT or PDGFR alpha, Other drugs may be more important. So some of those patients have a RAF mutation. Now, we're not sure whether in all of those patients that's what's driving their cancer. It's not enough to have a mutation. It's got to be a mutation that's doing something. So you need to know that you've got a target, but also that target, if you hit the target, that is going to have an effect. But we now have drugs that block mutated BRAF, and the mutations seen in GIST are the same mutations that those drugs will block. So that's something that's worth keeping an eye on. mTOR inhibitors, other drugs, all being looked at, and combinations are also being thought about. And of course, clinical trials. I've mentioned the masitinib trials, but we're always keen to look at these drugs in trials and try and have a portfolio of trials available for patients so they don't have to travel too far, but so that new treatments can be brought to all of you. I think something that's coming is rational dosing. So I've mentioned this idea of starting and stopping imatinib. That's not routine at the moment, but will the idea of drug holidays still be around? Will that prolong the time to the point where you have to change to a different drug? It's always nice to be using a drug that's working rather than going into the unknown with a drug that might not work. There's interest in imatinib blood levels. It looks as though the amount of imatinib in the blood tends to drop after a few months of treatment, and maybe that's got something to do with that influences how long people respond for. Functional response, should we be looking at how effectively the GIST is blocked? I think in practice we don't necessarily find that we need to be monitoring people with PET scans. CT scans tend to be useful, but certainly in people where you're trying to sort out whether they've got GIST or not, or whether this GIST is going to shrink when you're deciding on the timing of surgery, PET scan can be useful. And also, should we be doing biopsies on progression? Now that we're getting more drugs which are targeting different mutations in different exons, maybe that's something that we'll be looking at. So rather than just saying imatinib, sunitinib, regorafenib, we may be saying, well, you've got an exon 13 mutation, so we should use this, or you've got an exon 14, you should do that. And that, I think, isn't where we are at the moment, but maybe somewhere we'll go in the future. I think the things we think about, and certainly I think about in clinic, is the monitoring. How much do you scan? We now tend to scan the abdomen and pelvis rather than chest as well. How often do you scan? I've already mentioned that we're reducing the frequency of scans if we can. What blood tests do you do? Is there a good biomarker? Role of PET-CT. Role of surgery. When do we ask the surgeons to operate on a single nodule? Pause GIST. Not treading on those toes. Whether adjuvant treatment after primary medical therapy and surgery should be given. And also, once you've been through imatinib, sunitinib, regorafenib, anything else, should you then go back to imatinib? Is there still, particularly in people with symptoms, is there still a sensitive clone where you might be able to help someone? That's not something we routinely do, but something we sometimes think about. That's all I had to say. I'd be happy to answer questions maybe after Professor Wall's given her talk. Thank you.